Hello everyone, good evening. This is Dr. Priyadarshini, and in today's marathon series, we are going to look into the module Endocrinology. So the first hour, we are going to have the discussion on general endocrinology, pituitary axis, and overview and the disorders, thyroid, which is given a lot of importance in pregnancy, adrenal gland and its disorders, calcium, vitamin D and the homeostasis, pancreas and diabetes, yet another important topic. So, when we look into the hypothalamic pituitary axis, the hypothalamus is the key organ from where all your hormones are going to start acting. So, the releasing and the inhibiting hormones come from the hypothalamus, and then it reaches the pituitary. In pituitary, you have the anterior pituitary and the posterior pituitary. The anterior pituitary, the main hormones are, it is also called as adenohypophysis. Here, the main hormones include the growth hormone, which is driven by the growth hormone releasing hormone, and this is inhibited by somatostatin. Next comes your TSH, your thyroid stimulating hormone, which is stimulated by your thyroid releasing hormone. Next is your ACTH, which is your adrenocorticotropic hormone, which is driven by your corticoid releasing hormone from the hypothalamus. Next, you have your FSH and LH, gonadotropins, which has because of the pulsatile secretion of GnRH. So this word pulsatile is very, very important, which is seen in most of the SPAs. Next, you have prolactin. Points to remember is it is inhibited by dopamine. Now, all this belong to the anterior pituitary. Now, going to the posterior pituitary, we need to understand posterior pituitary is also called as a neurohypophysis. This serves as a storage and does not contribute to the synthesis and release of hormones per se. Now, what are the key posterior pituitary hormones? They are two in number. One is your oxytocin, which is very much important for uterine contractions and milk ejection. Whenever you have a question on lactation, ejection is because of oxytocin and synthesis or secretion is because of prolactin. Coming to the other key hormone of posterior pituitary, you have your antidiuretic hormone or vasopressin, which is generally used for water resorption. So these are the key hormones that you need to keep in mind. Next, you have to remember about the negative feedback. The negative feedback is basically the end hormones, the end organ hormones, which is going to inhibit your hypothalamus and your pituitary. For example, your thyroxine. Your thyroxine is going to inhibit your TSH and your thyroid releasing hormone. Your ACTH. So cortisol is going to have a negative impact on your ACTH and your cortical releasing hormone. So all these end hormones act as negative loop feedback. Now coming to prolactin. Now what are the key points you need to remember in prolactin? Prolactin is the only anterior pituitary hormone which is under the tonic inhibition of dopamine. So whenever there's a compression of the stalk, there is loose dopamine secretion there is no secretion of dopamine, like the dopamine secretion is lost. So because of this loss, there is an increase in your prolactin. So hyperprolactinemia is seen. Now what are the dopamine agonists? Cabergoline. This is used to treat prolactinemia. So prolactin is one hormone where most of the time we expect a question to come. So we were seeing at all the negative feedback mechanisms. So negative feedback is from your end organ hormones. Now coming to the pituitary disorders. Pituitary disorders, one common SBA that is seen is the most common cause of prolactinoma, which is nothing but your pituitary adenoma. Now coming to acromegaly. Acromegaly is nothing but the excess of growth hormone, and Cushing's disease is excess of ACTH. Sheehan syndrome. All these named syndromes are quite commonly asked in endocrinology. Now, what is Sheehan syndrome? Sheehan syndrome is nothing but because of postpartum pituitary necrosis, that is loss of these hormones. Diabetes insipidus, yet another common name to see in exam. Diabetes insipidus is because of your ADH deficiency, which is the central cause, or it can be because of the resistance, that is the nephrogenic cause of diabetes insipidus. Yet another common question seen in exams. So this mainly in your hypothalamic pituitary ovarian axis, what are the key points you have to remember? You need to remember hypothalamus. What are the hormones of anterior pituitary? What are the hormones of posterior pituitary? Next, the common syndromes that are associated with each of these hormones needs to be remembered. A special importance to prolactin and the commonest cause of prolactinoma. Now, anterior pituitary, we know it is your growth hormone, your TSH, ACTS, FSH, LH, and prolactin. Posterior pituitary is nothing but your antidiuretic hormone. Prolactin is tonically inhibited by dopamine. So dopamine agonists like cabergoline are used to treat prolactinomas. TRH is for TSH, CRH is for ACTH, and GnRH, pulsatile secretion of GnRH, is for FSH and LH. Your negative feedback mechanism is the one predominating for the control or regulation of these hormonal cycles. And Sheehan syndrome is the one that you see for postpartum pituitary necrosis. Most common cause of prolactinoma is pituitary adenoma. So whenever this is compression of the neurohypophyseal stalk, it leads to hyperprolactinoma. Posterior pituitary, you need to understand it is of neural origin. Next, coming to another very important topic, which is your thyroid physiology and pregnancy. Now, for thyroid physiology, let's start with the thyroid axis. The thyroid axis, as we just saw, it starts with your thyroid releasing hormone from your hypothalamus. From there comes your anterior pituitary, which is your thyroid stimulating hormone, and your end hormones are your T3 and T4. Now, T4 is called as thyroxine, which is your pro-hormone, and T3 is your active form, which is your peripheral deiodination, which gives to rise of T3 from T4. Now, reverse T3 is an inactive form of this T3. Now, most of this T4-T3 is bound to your thyroid binding globulin. Only the free hormone is active. So, the free hormone is the one which is associated with disorders. Now, what are the key changes that is seen in pregnancy? The key thyroid changes are your thyroid binding globulin increases because of estrogenic effect. So what happens is your total T3, T4 as such increases, but your free T4 is still normal in pregnancy. HCG has a mild activity because of similarity in the structure. So because of this, there's a dip or a fall in the level of thyroid stimulating hormone in the first trimester. And also there is increased iodine requirement that is seen in pregnancy. This is because the baby needs iodine, and also there's a renal loss of iodine that is seen in pregnancy. So what you have to do for pregnancy, you need to diagnose this disorder based on pregnancy specific TSH reference values. So the key changes that we saw, because of estrogen, the TBG increases, total T3, T4 is increased, but free T4 is normal. Very important. SBA, we saw the changes in HCG, we saw that iodine requirement also increases. The active hormone is T3, the inactive form is reverse T3. So, what are the common disorders you see in thyroid? We have hypothyroidism and we have hyperthyroidism. A hypothyroidism, what is the commonest cause? It is Hashimoto's or autoimmune thyroiditis. When a woman with Hashimoto's is not treated, this can lead to miscarriages. It is associated with preeclampsia and also a reduction in the IQ of the baby. So, if you look at the dosage of treatment with levothyroxine, usually there's a 25 to 50% increase in the dose in pregnancy as compared to a non-pregnant woman. So, how will you monitor these women in pregnancy? This woman needs to be checked for TSH in every trimester. The fetal brain development depends on the maternal T4 in the first trimester. Hence, it is very important to treat the woman as early as in pregnancy. Now, coming to hyperthyroidism. Hyperthyroidism, the most common cause here is Graves' disease. In Graves' disease, what do you commonly see? The TSH receptor antibodies will be present. So, what is the drug of choice here? Propylthiouracil in first trimester, and because if you use the other drug carbimazole, it can be associated with aplasia cutis. Carbimazole is safer to be used in second and third trimester. Now, what happens in Graves' disease? These antibodies can cross the placenta, and this can lead to fetal or neonatal thyrotoxicosis. Hence, the woman needs to be monitored and treated. You also have one more condition called as gestational thyrotoxicosis. Now, what happens in gestational thyrotoxicosis? It is because of HCG. Especially hyperemesis women can have this, and this is a transient state. It need not be treated. But the most important thing is this needs to be recognized or differentiated from Graves' disease. So we were looking at the common disorders here. We saw hypothyroidism in pregnancy and we saw hyperthyroidism in pregnancy. So the key exam points that you have to remember here, they can ask you the most common causes. They can ask you the drugs that you use in the first trimester and second trimester. And also they can ask you about transient thyrotoxicosis. So these three are potential SPs for your exam. So now let's look into the most common SBAs for your exams. Now, in the recalls, the first most important thing is your T3 and T4. Active form is T3, pro-hormone is your T4. Only your free hormone is active. And in pregnancy, because of estrogenic effect, your thyroid binding globulin increases. So what happens to your total T4? Increases, but your free T4 is still normal. Because of HCG, there's a fall of thyroid stimulating hormone in your first trimester. Hypothyroidism, most common is Hashimoto's. Hyperthyroidism, most common is Graves' disease. So what is the drug of choice for hypothyroid? It's your levothyroxine. There is an increase in dose of 25 to 50% as compared to a non-pregnant state. And how are you going to monitor them? Based on the TSH values. Now coming to drug of choice for hyperthyroidism, it is your first trimester, you use propylthiouracil, and second, third trimester, you go for carbimazole. And what is the side effect or adverse effect of carbimazole? It can cause aplasia cutis. So coming to the neonatal thyrotoxicosis, why is the baby at risk? Because these antibodies, the thyroid receptor antibodies, can cross the placenta, it can go to the baby and it can affect the baby. So these are some key points that you need to remember in your thyroid. Now, going into the next most common one, which is your adrenal physiology and its disorders. Now, when you look into the adrenal gland, very commonly asked question is a basic one to understand the various zones of the adrenal gland and what is the hormone that is released from these adrenal glands. If you look at adrenal, it can be divided into the adrenal cortex and the adrenal medulla. In the cortex, from outer to inner, the three layers are GFR, you remember. G is for glomerulosa, F is for fasciculata, and R is for reticularis. Now, what is the hormone that's released from glomerulosa? It's your mineralocorticoid. Example is your aldosterone. Coming to fasciculata, you have your glucocorticoids. The example is going to be cortisol, and for your reticularis, it is your androgen, that is your DHEAs gets secreted from your reticularis. Now coming to adrenal medulla is nothing your neural crest cells. You have your catecholamine released from here. Your adrenaline and noradrenaline gets released from your adrenal medulla. Now, when you look at the hormones of adrenal, your stress hormone is nothing but your cortisol. So, when there is an increase in glucose or it has an anti-inflammatory and anti-catabolic effect also. This cortisol has a diurnal rhythm. That means there's a peak of this cortisol in the morning. And why is it so? This is because of the control mechanism from ACTH. Another important thing that you have to remember here is about your aldosterone, which is your mineralocorticoid. Now, aldosterone is the one that is associated with your renin-angiotensin-aldosterone pathway, and this causes the retention of sodium and excretion of potassium. Now, where is the main action of this aldosterone? The aldosterone, it acts on the kidneys to bring in the changes. Now, one common disorder that is very commonly seen and asked in pregnancy is your congenital adrenal hyperplasia. Now, what happens in congenital adrenal hyperplasia? This is an recessive disorder, autosomal recessive disorder, and this is seen because of the enzyme deficiency. The most common enzyme that is deficient in congenital adrenal hyperplasia is your 21 hydroxylase deficiency. So what happens? Cholesterol gets converted into 17-hydroxyprogesterone, and this 17-hydroxyprogesterone must get converted into cortisol. So what happens is, because of the deficiency of this enzyme, there is accumulation of 17-hydroxyprogesterone, which serves as your diagnostic test for congenital adrenal hyperplasia. So CAH, what is going to be raised? It is 17-hydroxyprogesterone. What is the common enzyme that is absent here or deficient? It is your 21-hydroxylase deficiency. So what can happen to these babies? There is reduced in amount of cortisol, reduction in the amount of aldosterone. So what happens? The ACTH level rises. There is no feedback because your end hormone is not here. There is no feedback and your adrenal gets hyperplasia be there. So because of this, there is virilization. So this virilization can lead to ambiguous genitalia in the females. So which is the most common presentation of this or a most serious presentation of this? This is the classical congenital adrenal hyperplasia wherein you have salt wasting crisis. Now in salt wasting crisis, what happens? There is hyponatremia and hyperkalemia that is seen. And if it is a girl baby, at birth, if you see there is ambiguous genitalia. So identification of the genital is very, very important. Now, because of the lack of the cortisol, these babies can have hypotension and hypoglycemia. So whenever you have any baby who's quite lethargic at birth and it is presenting with this acute salt wasting crisis, you need to understand that the baby needs to be treated immediately. But when you look into the other forms of congenital adrenal hyperplasia, like non-classic forms, they will just have ambiguous genitalia and they might have a presentation quite late in life. But for 21 hydroxylase, especially with the classical form, treatment needs to be treated, the babies need to be treated at the earliest. So this is about the basic pathology in congenital adrenal hyperplasia. So, what are the other adrenal disorders that you should know about? Now, in congenital adrenal hyperplasia itself, you need to understand that the most common is your 21 hydroxylase. The second most common is your 11 beta hydroxylase deficiency. Now, looking into the other adrenal disorders, as I told, named syndromes. Named syndromes are a common thing that you see in endocrinology. Now, you have Cushing's syndrome. Now, what is Cushing's syndrome? This is because of excess amount of cortisol. The classical features here are going to be the individual is going to have moon face, striae in the body, and hypertension is quite common here. Now, let's look into Addison's disease. In Addison's disease, what happened? There is efficiency. Classical or key feature of Addison's disease is the pigmentation that the individual have, the bronze pigmentation we call as. And here the individual is going to have hyponatremia and hyperkalemia. Keep this in mind for Addison's disease. Now, what is Conn's syndrome? Now, Conn's syndrome is primary hyperaldosteronism, where you have excess amount of aldosterone, and hypertension is a classical feature of Conn's syndrome. Apart from this, one more disorder that you have to keep in mind is your pheochromocytoma. Now, what happens in pheochromocytoma? It is not your adrenal cortex, but it is your adrenal medulla. In adrenal medulla, we have catecholamines. And when these catecholamines are in excess, then you think about pheochromocytoma. Hypertension is again a classical feature of pheochromocytoma. So what are the potential questions that they can be asking here? They can ask you the hormones and from which zone of adrenal it is being secreted. They can ask you about any of these named syndromes. Now, for the named syndromes, I would suggest you to remember the name, the hormone that it is associated, and the classical feature by which you can diagnose it. Apart from that, they can give you a clinical scenario and they can ask you what is the disorder also. So for example, right from Conn syndrome to Addison's disease to Cushing's, any of these syndromes can come as an SBA. So you need to know a bit about the syndromes also when you revise them. So let's try to have a recall of what are the important topics we just saw in adrenal. We start with the adrenal cortex. Remember the mnemonic of GFR. For glomerulosat is aldosterone. For fasciculata it is your cortisol, and for reticularis it is your androgen. So these are the three important things you have to remember. First, next, going into the medulla crest, and this is where your catecholamines release, your adrenaline comes here. The most common cause of congenital adrenal hyperplasia is your enzyme deficiency, which is 21 hydroxylase deficiency. So what happens in this congenital adrenal hyperplasia? There's a reduction in the cortisol and aldosterone, and there's an increase in your androgens. So that classical test to diagnose this is your 17-hydroxyprogesterone. This level is going to be elevated in CAH. So CAH individual, they can have ambiguous genitalia because of increased androgens. It is seen in your female babies, and because of reduction in your cortisol aldosterone levels, they are going to have hyponatremia and hyperkalemia. This is an autosomal recessive condition. So the next important or the key topic that you have to remember is your calcium, vitamin D, and your bone. So if you look into calcium homeostasis, now calcium homeostasis, you need to understand that the serum calcium level is getting controlled because of various hormones at various levels, or various organs are being involved here. So whenever the calcium, when you're talking about what are the key enzymes or the hormones you discuss here? Parathormone from your parathyroid. Now, what does parathyroid do? This will rise your calcium levels. So, how can it rise your calcium levels? It will act on the bone. It will lead to bone resorption. It will act on the kidneys. It will lead to reabsorption of calcium, and it activates vitamin D. So, these are the main actions of parathyroid. Next, coming to vitamin D or calcitriol. What is vitamin D going to do? Again, it increases your calcium level, and it also increases your phosphate level. How? By bringing in gut absorption of this. The next one is your calcitonin. Where is calcitonin released from? It is released from the C cells of thyroid. Now, this is going to play an opposite action. That means it is going to bring down the levels of calcium. So these are the three things: parathormone, vitamin D, and calcitonin. Parathormone is from parathyroid. Calcitonin is from C cells of thyroid. So you have to know the origin also. So let us see how this parathormone actually functions. So parathormone acts on three different organs. One is the bone. So in bone, what it is going to do, you need to understand that the final action, it has to raise the levels of calcium. Okay. So a reduction in serum calcium level is the one that is going to activate your parathormone. So now this is trying to rise the levels, act on the bones, and it is going to activate your osteoclast. Okay. And it's going to activate your calcium and phosphate that gets released into the blood. So whenever osteoclast is there, what it is going to do, it is going to break your bones. So it is going to release calcium. Next, it is going to act on the kidneys. In the kidneys, we need more calcium to be reabsorbed from the kidneys and more phosphate to be excreted out of the kidneys. So how does it activate? It is going to activate your 1-alpha hydroxylase. So a role in kidney is dual. That means it is going to increase calcium, and as well as it is going to reduction in your phosphate. Finally, the action of parathormone on your gut, and this is indirectly via vitamin D. Now, what is it going to do? It is going to activate your vitamin D. You have 125 hydroxy cholecalciferol. Now, what is this going to do? This is going to increase your calcium and phosphate. Okay, so absorption from the gut is going to get increased. So how does the vitamin D activation, or how does vitamin D form synthesis generally happen? From the skin and from the diet, you have cholecalciferol. In the liver, you have 25 hydroxylation to have 25 hydroxy vitamin D. Now, when this reaches the kidney, you have 1-alpha hydroxylation. So the final product is going to be 125 dihydroxyferol. This 125 dihydroxycholecalciferol is the active form of vitamin D that you need to understand and have. So whenever the vitamin D levels are low, we know that the babies are going to get affected with rickets if it's a baby or a child, and in adults this can lead to osteomalacia. So this is how the vitamin D is regulated in the body. Now, what happens as such to the levels of calcium in pregnancy? In pregnancy, the total level of calcium is going to drop down. And why is it dropping down? Because of reduction in the levels of albumin that is seen. Now, active vitamin D. Active vitamin D is increased because of placental 1-alpha hydroxylase. The parathormone from the placenta releases almost 30 gram of calcium that gets transferred to the fetus. So the most important thing that you have to remember here is your parathormone. And what is your parathormone going to do? It is going to increase the level of calcium, and it's going to reduce the level of phosphate. So these are the key changes that you see in pregnancy. The total calcium is reduced. reduced, the active form of vitamin D is increasing, and also the calcium absorption is also getting calcium, and more than 30 gram is being released into the baby also. Now, what is the role of parathyroid releasing protein? That is parathyroid related peptide. This is seen. Why is this seen? This is seen because it is present in two different tissues. And what are they? They are the placenta and the breast. Now, what are the common disorders that you see here? The question on parathyroid related peptide is what are the tissues they will be seen? Nothing much has been asked in the past. Now, let's look into the disorders of this metabolic problems. The most common one is your primary hyperparathyroidism. We know from the name primary, it is affecting basically from the parathyroid, and it is hyper. That means increased amount of parathyroid. So what is this going to do? This can release your level of parathyroid, and in turn, it's going to elevate your levels of calcium. The most common cause being here is an adenoma from your parathyroid glands. Second thing is your hypoparathyroidism. Now, what happens in hypoparathyroidism? The parathyroid levels are low. So, in fact, this leads to reduction in the level of calcium. And this is very, very commonly seen after thyroidectomy, where the parathyroid gland is also removed by a mistake because of level of organs and also the placement of these organs right behind the thyroid. This is a common thing that we see in post-thyroid patients. Now coming to vitamin D deficiency. Now vitamin D deficiency, children it is rickets, adults it is osteomalacia. Now what is the daily recommended dose of vitamin D in pregnancy? It is 10 microgram, or in other words it is 400 international units per day. Again, a very, very important point to remember in exam, most commonly seen in the past. If you look at the level of phosphate, the level of phosphate is inversely related to the level of calcium. That means what? If your parathyroid is going to increase your calcium, this is going to reduce the level of phosphate. Again, a commonly asked SBA, the role between phosphate and its measurement to calcium. Remember, it is inversely proportional. So, now let's try to understand the key questions or the key recalls from this topic here. Main one is your parathyroid, and what does parathyroid do? It increases calcium. Vitamin D again increases level of calcium. Calcitonin is the only one that's going to reduce the amount of calcium. Now, vitamin D, skin you have skin you have the once there is hydroxylation in the liver, if you have 25 hydroxy cholecalciferol, and finally in the kidney you have the most active form of vitamin D, which is 125 dihydroxy cholecalciferol. This is the pathway of vitamin D. Now, pregnancy, as such, the level of calcium reduces. The ionized forms generally remain normal. In the placenta, you have 1 alpha hydroxylase. This increase leads to activation of vitamin D in the woman. Your parathyroid related peptide is the one that is seen from placenta, and your primary causes of hyperparathyroid is again because of adenoma. The same thing that we saw for pituitary. Remember for this also, primary cause of hyperparathyroid is from adenomas. Now, vitamin D deficiency, we know it's associated with rickets and osteomalacia, and this parathyroid always lowers phosphate. Vitamin D elevates phosphate, parathyroid lowers phosphate. So, those were the important topics we saw there. Next, going to yet another interesting as well as clinically very, very relevant topic, which is on pancreas and diabetes in pregnancy. Now, when you look at pancreas, what are the key hormones that you get from pancreas? You have your alpha cells, which release glucagon. So, what is glucagon going to do? It is a catabolic hormone. It increases your glucose level. Second is your beta cells, which release insulin. Now, what is insulin going to do? Insulin is anabolic. That means it's going to save in all the glucose. So, glucose gets converted into other elements which get stored in the body. Finally, you have delta cells which secrete somatostatin. Now, what are the key actions of insulin? Now, insulin glucose uptake. You'll remember that you're just having a meal. Now, what happens after a meal? The level of glucose is high. Why is it high? It is because of the GLUT4 receptors that are present in your duodenum and small intestine. And what does this GLUT4 do? It is going to increase the glucose uptake. Now, what is giving the signal for it to increase the glucose uptake? It is nothing but your beta cells. Okay, so beta cells, you have insulin. Now, insulin leads to glucose uptake. Um, the pathway for this glucose uptake or the receptor is going to be GLUT4. Now, what happens to the glucose? This glucose gets converted into glycogen and simple fats. Now, if you look at pregnancy, pregnancy as such is a diabetogenic state. Now, why is pregnancy a diabetogenic state? Because of these hormones which are anti-insulin or which causes insulin resistance. What are they? The key hormone which is associated with the diabetogenic state is your human placental lactogen that is released from the placenta. Apart from this, the other hormones that can act as contributory factors to the diabetogenic state is your cortisol and it's your progesterone also. Now, pregnancy, the diabetes is generally diagnosed in the second half of pregnancy after 20 weeks of pregnancy. Of the fluctuation of the glucose levels, the fasting glucose generally reduce. Why? Because the baby is also going to take in this. The fasting glucose is low and the postprandial level of glucose is quite high. Now, whenever there is a fluctuation in this glucose level, this can indirectly affect the baby. Now, how are we going to screen the woman for gestational diabetes? Screening OGTT is generally done at 24 to 28 weeks. However, it can be done earlier on pregnancy if she has any other complications or high risk history factors. Now, what do you generally do in this 24 to 28 weeks OGTT? The first thing is you look into the BMI of the woman. If the BMI is more than or equal to 30, then you have to think about going for treatment or therapy right now itself. And whatever previous medication she has used for gestational diabetes, the same can be continued here because there are very few drugs that are as such FDA approved for the use in pregnancy. However, till date, still the most effective and the one with least side effects is nothing but insulin. So always keep that in mind. Now, what are the main complications that a woman with gestational diabetes can suffer? She can go in for other medical complications like preeclampsia, oligo or polyhydramnios. Next, regard for the baby, what all can happen to the baby? Most common effect is macrosomia. You keep on eating and without your knowledge, all that glucose gets transferred into the baby. Now, what happens to the baby? The size of the baby increases and this is called as shoulder dystocia. Another very important thing, shoulder dystocia is associated with, remember the answer is going to be gestational diabetes mellitus. Now, next common thing that the baby can have is called as your polycythemia jaundice. Why? Because the baby has given more blood to the, because the mother has given more blood to the baby and the baby is macrosomic there, there's a high chance of this macrosomia leading to shoulder dystocia. And because the baby is of an increased size, what is happening here? The glucose level of the baby can drop down. So neonatal hypoglycemia is one thing you need to keep in mind whenever you're dealing with an infant of a diabetic mother. Next one is your polycythemia. Now, polycythemia can lead to neonatal jaundice and respiratory distress syndrome. Now, what is the key difference between a woman with gestational diabetes and a woman of over diabetes mellitus? Over diabetes mellitus is really associated with growth restrictions, but the mother is already diabetic before start of pregnancy. The second thing, coming to congenital anomalies. Now, anomaly risk is commonly seen with pre-existing diabetes. Macrosomia, shoulder dystocia, these are very much commonly seen with gestational diabetes mellitus. So, there is always a difference between gestational diabetes mellitus and a woman with overt diabetes. Now, let us look into the management of these women. You always start with diet. You put her on diet and lifestyle changes like exercise. If the glucose is just mildly elevated. Or the second will be the using of drugs. We know that the drug that is used in pregnancy is metformin or insulin. Now, when you start insulin earlier on itself, if you see the sugars are completely out of control, or if you see the woman is non-compliant with it, or any complications, you start her with the insulin itself. But for all women, you have to start generally with diet and lifestyle changes. Now, how do you diagnose this? You have to diagnose it based on OGTT. Now, what is the OGTT cutoff that we are looking at here? As per NICE, the fasting level of more than or equal to 5.6 or a 2-hour level of more than or equal to 7.8. So 5, 6, 7, 8. 5.6 is for fasting, 7.8 is for after 2 hours. Okay, so 5, 6, 7, 8 is the number that you use for screening test of OGTT. Now coming to the management options. Now, how are you going to manage them? You start with diet, you start with lifestyle changes, you see how the woman is responding. If they are responding with metformin, last option is going to be insulin. You start off with insulin earlier on itself if the woman is non-compliant or metformin is not working for her. Now, what are the other key questions you can get in exam? Say, for example, you already have a woman with a pre-existing diabetes. So, what is one important drug that you have to give the woman? Put her on high dose folic acid, which is 5 milligram of folic acid. Useful in your antenatal period and also in your pre-pregnancy period, whenever the woman is planning for the baby. Now, second thing is anomaly scan and miscarriage risk needs to be explained to these patients. It is important to have a detailed anomaly scan, and it's also important to know that there is still a chance of miscarriage slightly higher than that compared to the. So we saw the key values that you have to remember here is 5, 6, 7, 8 as per the NICE guideline. GDM, the chances of congenital anomaly is there but still on the lower side. The most important thing is respiratory distress in the baby. It can cause shoulder dystocia and macrosomia. These are some very, very commonly seen things. So we were just trying to discuss in detail how the GDM screening is done. Now, what are the risk factors which puts the woman at a high risk? So we have to screen it earlier on. One will be a BMI more than or equal to 30, previous history of GDM, the family history of diabetes, and previous macrosomia. Ethnicity like the South Asian, Black, and the Middle East are at a high risk of developing this diabetes. Now, how are you going to diagnose? We just saw it is going to be 5, 6, 7, 8. So any value of fasting more than or equal to 5.6 or postprandial more than or equal to 7.8, then you diagnose GDM. So GDM, the most common complications in the mother, preeclampsia, operative vaginal delivery, polyhydramnios are quite common. For babies, it can cause macrosomia, shoulder dystocia, and hypoglycemia. So that is going to be, you're going to add on the woman with exercise. If not, in 2 weeks, start her on metformin or insulin, depending on her presentation. So what are the key factors we just saw for pregnancy and diabetes? The beta cells is for insulin and the alpha cells is for glucagon. So first thing is you look into the hormones and the cells that are associated with the hormones. Second thing you need to remember, pregnancy is a diabetogenic state because of what? It is mainly because of the human placental lactogen, which is from your placenta. This is resistant. This makes the woman resistant to the glucose changes. Next, what happens here? The and the postprandial sugars are quite high in these women. Routine screening is your OGTT, and when it is done between 24 to 28 weeks. But look into the scenario in your exam. In case they have mentioned some high risk factors for developing diabetes, then you are entitled to do an early OGTT also. The treatment of choice here is going to be depending on the values of the sugar that you have. Fasting more than or equal to 5.6, post food like 2 hours, a post glucose test 2 hours, if it's going to be 7.8, that is 5, 6, 7, 8, that makes your diagnosis. And how are you going to treat these women? You start with your diet and you start with some in 2 weeks time. If it is not getting controlled, then you switch over to the medications still to date insulin is the first choice. However, if the woman is non-compliant, there's just a slight fluctuation of sugars, then metformin is a good additive that can be used to these women. GDM is generally not associated with your congenital anomalies. GDM is most commonly associated with your neonatal hypoglycemia. It is most commonly seen with macrosomias. These are the common things with GDM. Whereas your congenital anomalies are generally linked with a case of overt diabetes. If a woman has already got diabetes, then the folic acid dose is going to be 5 milligrams. So these are some key points you need to remember about diabetes. Now, what did we see so far? We discussed quite some important topics. We started from the hypothalamus, then we looked into the pituitary hormones and we see how the full loop was working. We looked into thyroid disorders, we looked into adrenal disorders, and finally we had a word about pancreas. Apart from this, one important thing of pancreas is they can ask you the changes in a well-fed state and they can ask you the changes in a starved state. In a well-fed state, you have just taken food, your glucose is going to be high, so your insulin is going to come and act. In a starved state, already your body is not having glucose. Glycogen needs to be converted into glucose. So glycogenolysis or the opposite of your glycolysis is going to take place. So this is something you need to keep in mind. So which is the hormone that acts in your fasting state and which is the hormone that acts in a well-fed state. This is another important point when you look into your exam preparation. Now, what are we going to do? We are going to look into some important MCQs which is associated with these topics. So, the most common question here, which anterior pituitary hormone is under a tonic inhibitory control? So, with this word of tonic inhibitory control is seen with only one hormone, and what is it? It is nothing but prolactin. Now, the prolactin is inhibited by dopamine. And loss of this dopamine, that means whenever there's a stalk compression, the pituitary stalk compression, that leads to loss of dopamine, and this will lead to hyperprolactinemia. And what is the most common cause of hyperprolactinemia? It is nothing but your pituitary adenomas. This is something that you have to keep in mind. Now, what are the drugs that are used for treatment? You use your dopamine agonist. The dopamine agonist example is your cabergoline. Now, next question. Postpartum pituitary necrosis following a major hemorrhage. Generally, it is seen after major postpartum hemorrhage. What is this syndrome called as? This syndrome is called as Sheehan syndrome. Now, you need to remember that many questions can be targeted in the same way. So, a quick exam tip is going to be write down all the syndromes associated with the disorders and just at least understand to which organ or to which endocrine gland this is associated with. So, Sheehan syndrome is following a major postpartum hemorrhage, postpartum pituitary necrosis take place. So, how is the woman going to present to us? The woman is going to have failure in lactation. She's not able to have breast secretion. She will have hypopituitary features. Okay. So the entire pituitary is undergo necrosis. So all the pituitary hormones are not going to work. Coming into next question. Thyroid. Thyroid is given a lot of weightage in exam. Expect at least 1 or 2 questions from thyroid. So let us look into the question here. In normal pregnancy, the total T4 rises, but the free T4 stays normal. And why is this so? Is it because the thyroid enlarges? Is it because the estrogen increases your TBG? HCG destroying T4? HCG rises sharply or iodine intake falls? Now, this is mainly because of your thyroid binding globulin, which is under the effect of estrogen. So what happens? This will lead to more bound form of T4, T3. So what happens? Your total hormone rises, but your free hormone still becomes normal. Coming to the drugs, which anti-thyroid drug is preferred in the first trimester? Now, first trimester, your drug of choice is going to be propylthiouracil. Second and third trimester, it is your carbimazole. And what is the main side effect of carbimazole? C for C, C for carbimazole, C for cutis. So, carbimazole causes aplasia cutis. Keep this in mind. Okay. Coming to some other important questions. The commonest enzyme deficiency that is seen in congenital adrenal. The most common enzyme that is deficient here is your 21 hydroxylase. Second one is going to be your 11 beta hydroxylase. Third common one is going to be your 17 alpha hydroxylase. All these three questions were seen in the past. Most common most common enzyme is your 21 alpha hydroxylase deficiency. Second most common is your 11 beta hydroxylase deficiency. Third most common is your 17 alpha hydroxylase. So very, very important one. Keep this in mind. And how are you going to diagnose congenital adrenal hyperplasia? There is going to be an elevation of 17 hydroxyprogesterone. This is the diagnostic test for your CAH. Which zone of the adrenal cortex produce aldosterone? So knowing the zones of adrenal, the cortex, the three areas of cortex and one area of medulla. Okay. So cortex producing aldosterone. So how did we remember it? GFR, glomerulosa fasciculata reticularis. Your glomerulosa produce aldosterone. Fasciculata is for your cortisol and reticularis is for your androgens. This is how we remember. Now, which hormone rises your calcium levels and lowers your phosphate? Calcium homeostasis. Now, what are the hormones that are associated here? We have calcitonin, we have parathormone, insulin, cortisol, aldosterone, of course, not associated with this. So, is it going to be calcitonin or is it going to be parathormone? The parathormone raises calcium level. How is it going to raise the calcium level? It causes bone resorption. It causes reabsorption of the calcium from the kidneys and it activates your vitamin D levels. What else does parathormone does? It is going to lower the phosphate level also. What does vitamin D do? Vitamin D raises both calcium and phosphate. So this is the catching point here. And what is calcium opposite? It's going to reduce your calcium level. So this is the key difference between your parathormone, your vitamin D and your calcitonin. All three are associated with maintenance of your calcium levels. Now, coming to another very significant clinical disorder in pregnancy, it is your gestational diabetes. Now, gestational diabetes, we have a complete guideline on this. Now, let's look into the question. Gestational diabetes is diagnosed by your NICE guidelines by a fasting glucose of what? So various values are given here. As I told you earlier, 5, 6, 7, 8. Keep that number in mind. Fasting more than 5.6, 2 hour more than 7.8. It's more than or equal to. Okay, so fasting is more than or equal to 5.6 and your 2 hour is more than or equal to 7.8. Then you diagnose your gestational diabetes. Okay, so this is something you need to keep in mind. And gestational diabetes is big babies and pre-existing diabetes, that is your over diabetes, is small babies, that is IUGR, and your congenital anomalies is for your pre-existing diabetes. Going into the next MCQ, which is on again on diabetes. That is seen with pre-existing diabetes, but not with gestational diabetes. Macrosomia, gestational diabetes. Congenital anomaly, it is seen with pre-existing diabetes. Okay. Neonatal hypoglycemia, again seen in big babies, so it is seen in gestational diabetes. Polyhydramnios, again seen in gestational diabetes. And shoulder dystocia. How shoulder dystocia takes place? Again, because of macrosomia, which is seen in gestational diabetes. So what is the complication that we are seeing here? We are looking at congenital anomalies. So pregnancy is a diabetogenic state. And why is this because of? Is it because of increased insulin secretion or is it because of human placental lactation, which causes resistance, reduced cortical renal glucose reabsorption, and fetal insulin crossing the placenta? Remember, this diabetogenic state in pregnancy is because of multiple factors, but the key cause of this diabetogenic state is your human placental lactogen, which is going to be an anti-insulin one, and it causes insulin resistance. So this is the key change that causes the diabetogenic state of pregnancy. So far we looked into the core endocrinology and the main endocrine organs over which or in and around which your questions can be targeted at. Now, The second hour of endocrinology is going to be dedicated to reproductive endocrinology. Again, you can expect minimum of physiology itself. So how are we going to divide this? We are going to look into the basis of reproductive endocrinology. We are going to look into the hypothalamo-pituitary-ovarian axis. We are going to look into the changes in puberty and some pubertal disorders. Your polycystic ovarian syndrome, a lot of importance is given to that. Amenorrhea, the changes that are seen in amenorrhea, diagnosis, and hyperprolactinemia cannot be stressed more. These are two very, very common syndromes that are seen in pregnancy. You can have a clinical discussion on any of these topics. Next thing is menopause and HRT, another hot topic that is seen in your exams. And then a few disorders associated with androgen like virilization, hirsutism. These are other areas in which questions can be targeted at. So, to start off with your hypothalamo-pituitary-ovarian axis. Now let's see what are the key points to remember here. This hypothalamo-pituitary-ovarian axis gets activated at puberty. And what activates it? It is the pulsatile secretion of your gonadotropin releasing hormone. The word pulsatile is a key factor here. Whenever the pulsatility is lost, it leads to the dysregulation or dysfunction of your HPO axis. Now, once you need to understand what is the sequence at which it happens. The normal age of puberty is considered as 8 to 13 years. Any puberty less than 8 years is called as precocious puberty. And for boys, it is taken as before 9 years. Now, let's look into the sequence of events that are seen in puberty. The first sign of puberty is the development of breast. This is called as telarchy. The second sign is your pubarchy or the development of pubic hair, which is your androgenic effect. The growth spurt is the one that follows, but you also need to understand growth spurt can be seen with any of these changes. And the last change that you see is your menarche or the first period in a woman. Now, dysmenarche is generally seen 2 years after the onset of telarchy. So, for example, a girl gets the breast budding at, say, around 10 years. You can expect a menarche somewhere around 12 to 13 years. This is the sequence of puberty. And how do you actually monitor or you see the development of puberty? It is via a staging called as Tanner staging. The Tanner staging gives a detailed documentation and it also gives a progression of all the changes that you can see in these young children. Now, what is the drive force for this pubic hair development and the axillary hair development? This is your androgen. Why is it important to know here? If you have a clinical scenario and they mention there is absence of pubic hair, absence of axillary hair, remember if your androgen is at fault there. The average age of menarche is generally taken as 12 to 12.5 years. Now let's look into the key pubertal dysfunction or disorders. One is your precocious puberty, other one is your delayed puberty. Precocious puberty means it is occurring quite early. And what is the age cutoff here? It is 8 years for girls and 9 years for boys. And what are the key factors or the key etiology for this? Central precocious puberty, or it can be GnRH independent or your peripheral precocious puberty. The central precocious puberty means as an early axis activation. It is from the central causes. But if it is peripheral causes, it can be either from the source of ovary or adrenal that can lead to peripheral causes. Now, how are we going to investigate? We are going to look at a sequence of investigations. We are going to look at the luteinizing hormone levels. We are going to look at the GnRH levels to understand the cause of precocious puberty. Now, looking at the delayed puberty. Now, what is delayed puberty? The woman or the girl has not got telarchy by 13. That is, there is no menarche by age of 15. You diagnose delayed puberty. This delayed puberty can be constitutional delay, which is the most commonest cause of delayed puberty. Apart from that, the most common causes are hypogonadotropic causes like Kalman syndrome. Kalman syndrome key features is anosmia with reduced amount of GnRH. So another syndrome we are coming across here, which is Kalman syndrome. Second thing can be hypergonadotropic, that is increased amount, which is seen in gonadal failures like Turner syndrome. So these are the most common cause of delayed puberty. After this, another important disorder of puberty is your primary amenorrhea. Now, what do you mean by primary amenorrhea? A girl has not got menarche by age of 15, or she is 13 years but she has not developed secondary sexual characters. Then you label her as primary amenorrhea. Again, the most common cause here is going to be a delayed puberty. Now, let's look into the common questions that you can expect in puberty and pubertal disorder. First thing is, what is the first sign of puberty? First sign of puberty is thelarchy. Thelarchy is nothing but breast bud formation. Second thing, which is the last event or what is the average age of menarche? Menarche is the last event to come, and it normal puberty 8 to 13, less than 8 years is precocious puberty, and if there is no breast bedding by 13 years, think of delayed puberty. Kallmann syndrome, the only named syndrome that I mentioned right now is Kallmann syndrome. Key feature of Kallmann syndrome is anosmia with reduced amount of GnRH. Turner syndrome is your 45XO, which is associated with hypergonadotropic causes. Always any scenario with low pubic hair development, it is because of adrenal problems. So adrenarche is driven by your adrenal androgens. And whenever you're talking of central causes of precocious puberty, central causes are always GnRH dependent. Peripheral causes are always GnRH independent. So what are the peripheral causes? The peripheral causes can either come from the ovary or it can come from your adrenals. So, next we are going to yet another important topic, PCOS. We know recently the name has been changed into PMOS, but of course for this exam, you just remember PCOS itself. So, which is the most commonest endocrine disorder in reproductive age group of women? It is PCOS. Now, what is the incidence of it? It is almost 10%. Now, how do you diagnose PCOS? PCOS is diagnosed with the Rotterdam criteria. The Rotterdam criteria says at least 2 out of the 3 criteria must be fulfilled to label a woman as PCOS. Now, what are they? First one is a change in periods. Periods can either be oligo or anovulatory. That means irregular periods or absent periods can be seen in this women. Or there can be hyperandrogenism, that is excess feature of androgen. And this can be either a clinical feature like, excess hair development in abnormal areas, or there can be just biochemical hyperandrogenism. In biochemical hyperandrogenism, there will be increased amount of testosterone levels. The last feature is the appearance of polycystic ovaries in your ultrasound. Now, how do you diagnose this in an ultrasound? If you're using a high resolution ultrasound, then the number is going to be more than or equal to 20 follicles. If you're using a normal resolution ultrasound, it still remains as more than or equal to 12 follicles. Keep this in mind. Second thing is the ovarian volume. Whenever it is more than 10 ml, then it is diagnostic of ultrasound. So you need to keep in mind any 2 out of these 3 features are present, then you label the woman as PCOS. Most important thing, you have to rule out other causes that can be similar to this, like congenital adrenal hyperplasia, Cushing's, androgen tumors, hyperprolactinemia. All this needs to be ruled out in these women. So what is the basic pathophysiology that you see in a case of PCOS? Now, in PCOS, there is insulin resistance, which is the key factor which causes all the changes in these women. Because of insulin resistance, there is hyperinsulinemia. If you look at your hormone levels, what happens? There's an alteration in the level of FSH-LH ratio. So there is increased LH compared to FSH. Next, what happens is the ovarian androgen level rises and your sex hormone binding globulin level reduces. So whenever the binding globulin reduces, your free testosterone increases and that leads to your androgenic features. This is the basic pathophysiology that you see here. So what can the woman present to you with? They can present to us with menstrual disorders. They can have subfertility. They can have acne and hirsutism related features, obesity, or they can have acanthosis nigricans, which is nothing but extra hyper in the axillary region. So what are we going to do for the management? The key factors is lifestyle changes, and weight loss. So very commonly asked question on PCOS, what is the first line of management? Remember, it is always the lifestyle factors that we are going to talk about. Second thing is going to be the use of medications. You can use COC, your combined oral contraceptives. This can be used for the regularization of the cycles, and it can also have some anti-androgenic effect on the woman. Next, for insulin resistance, we can put the woman on metformin. And if the woman has got subfertility and you have diagnosed she has got anovulatory cycles, then you can give her letrozole, which is used. Second line, you can go in for clomiphene citrate. Always remember that these women are at very high risk of developing endometrial hyperplasia later on. So whenever you're using estrogen, your endometrium needs to be supported. Do not use unopposed estrogen for a long time in these women. So long term, what are the complications that they might go into? They can have type 2 diabetes mellitus developing quite earlier in life. They can have metabolic syndrome because of all these changes, and there's a high risk of developing endometrial cancer in these women also. So these are some key long-term complications of PCOS. The most important thing here, not all women will be PCOS, so you have to this. This is again a potential SBA that can come. So we looked into the clinical features of PCOS. We looked into the most common complications. Endometrial hyperplasia and malignancy is one of the things that people generally forget in exam. So keep that in mind also. Management, first line is always weight loss. Okay. This is an SBA that has been repeated quite commonly in the past. Second one is the use of drugs, which is your combined oral contraceptives, metformin, and you will use ovulation induction only if the woman has presented with subfertility. And always remember, endometrial protection needs to be taught in these women because they are at very high risk of developing endometrial hyperplasia, which in turn can turn into endometrial cancer. So these are some important points you need to remember about PCOS. Another important thing about PCOS is you can have an image-based question. They can give you an ultrasound picture. In an ultrasound, they can show you this ovaries. So how is it going to appear? It is going to be like a string of pearl appearance. You'll have the ovarian stroma, and towards the periphery, you'll have multiple small follicles. Any such picture, think about PCOS. So what are the most commonest endocrine disorder of reproductive age is PCOS. Diagnosis is with Rotterdam criteria. 2 out of 3 must be present. And what are the 3? It is your menstrual disturbance, oligo or anovulation, hyperandrogenism, which is either clinical or biochemical, and your ultrasound picture. You have to rule out other important factors like Cushing's, adrenal tumors, ovarian tumors, and congenital adrenal hyperplasia before you finalize your PCOS. What is the main key pathophysiological feature you see here? It is insulin resistance. And what are the key hormonal changes you see here? Increase in your LH-FSH ratio, increase in your free testosterone level, and reduction in your sex hormone binding. Now, what is acanthosis nigricans? Because it's a different name that's coming up here. Acanthosis nigricans is nothing but the hyperpigmentation you see in the nape of the neck and in your armpits. And why is this? This is a sign of insulin resistance in these women. These women with PCOS are at very increased risk of developing endometrial cancer. Why is this so? This is because of unopposed estrogen that is present in them. First line of treatment, always weight loss. Weight loss can be through diet and through physical activity, change in lifestyle. The first line of drug for ovulation induction is going to be letrozole, and the first drug for insulin resistance is going to be metformin. So you will choose the drug depending on the whatever scenario that's been given to you, because PCOS can the clinical scenario that can come to you in exam can either be for regularization of periods, or it can be for subfertility with anovulation, or it can be just for insulin resistance. So your answer will be chosen depending on the scenario that's been presented to you. Always keep this in mind. So next important topic of your reproductive endocrinology is anemias. Now, what do you mean by amenorrhea? Amenorrhea is any woman who hasn't got periods. However, when you come to clinical scenarios, you need to distinguish between primary amenorrhea and secondary amenorrhea. Now, what do you understand by primary amenorrhea? Any girl who hasn't got periods by age of 15, or she's 13 years but she has no secondary sexual characters, you name her as primary amenorrhea. Now coming to secondary amenorrhea. Now it's been more than or equal to 6 months she has not got her periods. Then you take it as secondary amenorrhea. First point, most important clinical point here. Any case of amenorrhea, first exclude pregnancy. Let it be even primary amenorrhea. The first thing that you have to rule out is pregnancy. So do a beta HCG test in these women. The second thing will be the causes of amenorrhea. The causes can start, you have to, whenever you think about amenorrhea, you go back to your hypothalamic pituitary ovarian axis. So the causes can start from your hypothalamus. It can be at your level of pituitary, or it can be at the level of ovary. Or what else can happen? All the three levels are okay, but your end organ, that is your uterus, is not functioning properly. So there can be an outflow destruction. So all of these will be the causes of amenorrhea. So let's start with hypothalamus. So hypothalamus, what happens? There can be reduction in your gonadotropin releasing hormone. So what can happen here? There can be excessive stress in the woman, or excessive exercise, which is seen in athletes, or low body weight, anorexia nervosa. All these women can have reduction in your GnRH, which is directly in your hypothalamus. Kalman syndrome is another important cause of a hypothalamic cause of amenorrhea. So what is the key feature that you see here? Your FSH, LH level are going to be low and is going to have hypogonadotropic state if hypothalamus is the cause of amenorrhea. Second, let us look into pituitary. If you look at pituitary causes, what happens? Your FSH, LH levels are going to be low. Another cause of pituitary is your hyperprolactinemia. So hyperprolactin, whenever the level of prolactin is going to be high, what happens to this increased prolactin is going to suppress your GnRH. So this suppression of GnRH will indirectly lead to amenorrhea. Another thing is your Sheehan syndrome, postpartum pituitary necrosis. This is one of the causes of pituitary disorders leading to amenorrhea. So whenever you're ruling out amenorrhea causes, always look at prolactin levels. And if your prolactin is high, what is the drug of choice? You have to use dopamine agonists like cabergoline. Next, coming to the ovarian causes. Now, when you look at the ovary is your end organ, right? So, when you look at your end organ, what happens is your preliminary hormones are going to be high. What are the preliminary hormones here? Which is your FSH and LH. So, if your ovary is at fault, your FSH, LH levels are going to be high. So, they are going to have hypergonadotropism, or they can have eugonadotropism also. That means normal also. And what is the most common cause in your ovary which causes amenorrhea? It is your polycystic ovarian syndrome. Apart from that, there can be premature ovarian insufficiency, POI. Now, what is premature ovarian insufficiency? It is seen in a woman who is less than 40 years, whose FSH level is more than or equal to 25 in two different occasions. You label the woman as premature ovarian insufficiency. And most common cause is going to be genetic disorders for this. Apart from that, any syndrome that can come across is the Turner syndrome. And Turner syndrome is diagnosis based on karyotyping. However, for your ovarian disorders, remember your high FSH will be seen, that is hypergonadotropic. Hypothalamus, it is going to be hypogonadotrophic. In ovary, it is going to be the opposite, the reverse of it. It is going to be hypergonadotropic. So this is how, whenever you get a clinical scenario, you will be looking at your FSH LH levels and you will be diagnosing the possible level of cause of the amenorrhea. Now, if there is nothing to do with your hormones are all normal, then you come to the final organ, which is your uterus. So what happens? There can be an outflow deformity or defect in your uterus, which is leading to primary amenorrhea. So where else, where and all can the problem be? The problem can be in the cavity. In the cavity, it can be because of Asherman syndrome. What is Asherman syndrome? It is intrauterine adhesions, most commonly seen after DNC or any intrauterine procedures. Second thing is the uterus is fine, but there is a problem with at the outflow, just at the exit. It can be seen in cases of imperforate hymen or transverse vaginal septum. This can be the causes. Or very unlikely, the uterus is not develop or underdevelop or absent. It can be seen in agenesis of your upper vagina, or it can be associated with syndromes like Mullerian-Rokitansky syndrome. What happens in MRKH syndrome? In MRKH syndrome, your uterus is going to be absent. Okay. So these are the conditions in which the final organ, the uterus, is at fault. So whenever you have a clinical scenario to deal with amenorrhea, you have to see first thing whether we are dealing with primary or secondary. Then depending on your FSH levels, you're going to identify the level of amenorrhea, hypothalamus, pituitary or ovary. If everything is fine, then finally you're going to look at your uterus to understand whether uterus is at fault. Again, in uterus, I told you have to look at the cavity, Asherman syndrome. You look at the outlet, it's your imperforate hymen or transverse vaginal septum. Overall uterus is absent, then you're dealing with MRKH syndrome. So the most common things that we saw just now, one is your hyperprolactinemia. Hyperprolactinemia is given a lot of importance, and most of the times we expect at least one question here. Another question that can come around your hyperprolactinemia is the drugs that can cause hyperprolactinemia. What are the drugs that can cause? We saw hyperprolactinemia is treated with dopamine agonists like cabergoline. So the drug that causes hyperprolactinemia are going to be dopamine antagonist, antipsychotic medications, metoclopramide, all of them are dopamine antagonist. And the stock effect we already saw. So any stock that is going to, any problem that is going to affect your pituitary stock can cause your problem with your prolactin levels. So premature ovarian insufficiency, this POI will be given a lot of importance in exam because we have an entire guideline on that. How do you diagnose it? Menopause before 40. So the age of the woman is less than 40. She has high FSH, she has high LH, she has low estrogen. It is premature ovarian insufficiency. So the most common cause I told can be genetic disorders. It can be idiopathic or related to any surgery or radiotherapy. How are we going to diagnose the level of amenorrhea? It is based on your FSH values. So just to have a recall of what all we just discussed on amenorrhea and hyperprolactinemia. First thing, secondary amenorrhea is more than or equal to 6 months after the period at any time in any time. And always rule out pregnancy first. Let it be primary, let it be secondary, whatever it is, you have to rule out pregnancy first. Hyperprolactinemia, why does it cause amenorrhea? Because it suppresses your GnRH. Hypothyroidism causes increase because of stimulation with your thyroid releasing hormone. Dopamine antagonist, key example is your antipsychotics. It increases prolactin. So what is the treatment of this prolactinoma? It is with your dopamine agonist. Most common drug we use is cabergoline. Other drug is going to be bromocriptine. So prolactin is given a lot of importance here. Coming to premature ovarian insufficiency, menopause less than 40 years. How do you diagnose it? FSH levels. What is the value of FSH? It's going to be 25 on two different occasions taken 4 to 6 weeks apart. This is a very, very key important point. I'm repeating it once again. Premature ovarian insufficiency is diagnosed in a woman less than 40 years who has got menopause. And what do you do with the labs? In the lab, you look at your FSH values. There will be at least two values of FSH in which the level is going to rise more than 25. And the two occasions are going to be at least 4 to 6 weeks apart. And how do you understand the level of amenorrhea? Whenever your FSH is high, you're dealing with an ovarian cause of amenorrhea. Whenever your FSH level is low, you're dealing with hypothalamus or your pituitary causes of amenorrheas. And Asherman syndrome, again a named syndrome. Asherman's is nothing but intrauterine adhesions, most commonly seen after post-curettage, post-DNC of uterus. This can be seen. And Mayer-Rokitansky syndrome is nothing but absent uterus. So this was all about amenorrhea and hyperprolactinemia. So next, let's look into yet another important topic over which you can expect a lot of questions because this is a hot topic both in the clinical practice and also the guidelines have been updated on menopause. Now, menopause is nothing but there's a permanent cessation of menses. So, what is the time duration that you give for menopause? The time duration is taken as at least 12 months of amenorrhea. What is the average age of menopause? Average age is taken as 51 years. Now, what do you understand by climatic phase? Climatic phase is nothing but the perimenopausal phase, and this is nothing but a transition period. This transition period can take any time between 3 to 8 years. Now, what is premature menopause? Premature menopause is any woman going into menopause less than 40 years is taken as premature menopause. Now, in menopause, what are the questions you can expect? All of them, what I said just now, can come as a question. Apart from that, all the hormonal changes in menopause can come as SBA. Now, what are the important hormonal changes? What happens in menopause? The follicles of the ovarian follicles will get depleted. So, estrogen goes down, inhibin go down. So, whenever estrogen goes down, what happens is the negative feedback the estrogen has on your HPO axis is lost. So, which is the hormone that's going to rise here? It is your FSH. So, FSH level is going to be elevated, and the key marker or factor that is going to help in diagnosis is the level of FSH going 30 internationally. With your FSH, your LH is also going to be raised. So, clinically, if you want to diagnose any woman more than 45 years not having periods for 1 year, then you can still diagnose menopause. Less than 40 years, when you're thinking of premature menopause or premature ovarian insufficiency, always go with FSH levels. And then coming to the symptoms. Now, what are the symptoms the woman can present with? First thing is, of course, there's going to be absence of periods, which might be bothering her, which might not be bothering her. But there are some key factors or key features of menopause that can actually bother the woman. So what are they? The woman can have vasomotor symptoms. In vasomotor symptoms, we talk about hot flushes, night sweats, and all that. The woman can have disturbance in mood. A lot of anxiety and depression is quite common here, and there can be vaginal atrophy. So atrophic vaginitis is very, very common here. And because of this loss of estrogen, it is not only the vagina, the entire urogenital system can undergo atrophy. And because of reduction in estrogen, the woman might experience some sexual disturbances like reduced libido. Now, these are all with the reproductive system per se. Now, what are the other general effects because of hypoestrogenism? Most common one is your osteoporosis. These women risk of fracture. Hence, you have to look at their DEXA score and you'll have to keep them on treatment for osteoporosis. Second most common thing you have to keep in mind is the loss of the protective cardiovascular effect of estrogen. So the cardiovascular risk increases in these women. So apart from the reproductive system, these are the other two main things that any menopausal woman can have. So, for menopause, what are the other key exam topics that you have to remember is the treatment of menopause. Treatment of menopause can be non-hormonal treatment or hormonal treatment. Now, let's discuss about hormonal treatment. Now, hormonal treatment of menopause or hormone replacement therapy is basically we are going to give the woman hormones to combat the effects of menopause. So, what are the hormones we are going to give the woman? We are going to give the woman progesterone. We are going to give the woman estrogen. So what are we going, like what are the key factors that is going to help us understand what are we going to give the woman to? Now, whenever the woman has no uterus, like say hysterectomy, post-surgical menopause, you give the women only estrogen. Why only estrogen is enough for the woman? There is no endometrium. So whenever a woman has endometrium, that endometrium needs to be protected from unopposed pitch in progesterone also. So if there is no uterus, remember you give the woman only estrogen. If the woman has uterus, then you give the woman both estrogen and progesterone. With this progesterone is the one that is going to protect the endometrium. So the simplest regimen that any woman can have is the estrogen alone. And again, depending on the type of symptoms, if it is only vasomotor symptoms, you can treat her separately. If it is only vaginal estrogen she requires because of, vaginal atrophy, you can treat her separately. Now, what happens to the woman who's got uterus? You have to put her on combined estrogen and progesterone. So generally, you can put the woman on cyclical or continuous use of these drugs. So another important thing that we are talking about this menopausal woman is the long-term consequences for osteoporosis and the cardiovascular risk. Okay. Now, whenever you put the woman on unopposed estrogen, we just saw the woman can develop endometrial hyperplasia and endometrial cancer. This is the reason you add progesterone for any woman who has got uterus. Okay. Now, what are the risks of this hormone replacement therapy? Now, hormone replacement therapy, the most commonly associated one is your venous thromboembolism. The venous thromboembolism is more commonly seen in women who takes an oral form of HRT rather than a transdermal form. And breast cancer. Breast cancer is generally seen in a woman who has taken combined HRT regimes. The other common side effects or adverse effects here are stroke and all that. And whenever you're using transdermal route of HRT, then you're avoiding the first pass effect and your VTE risk also reduces. So what are the various ways you can give the HRT, hormone replacement therapy? It can start from oral drugs. You can start from transdermal patches, you have spray, so multiple routes are there. The best route for system, if the woman has got systemic effects, then you have to give her oral route, or if she has got high risk factors for developing VTE, then you can give her transdermal route also. Now, what are the key benefits of hormone replacement therapy? The key benefits are the symptom relief. Whichever symptoms is presenting with, HRT is going to act against that. And bone protection is also seen in this women with HRT. Now, what are the main key contraindications to hormone replacement therapy? One is breast cancer. Any woman who's got active breast cancer or a past history of CA breast, this you're not going to give them hormone replacement therapy. VTE. Any woman who's got a history of VTE in the past, especially an unprovoked VTE, you have to keep that in mind. Undiagnosed vaginal bleeding, you don't know what is the cause of bleeding here. Don't put the woman on HRT. You'll have to make her understand, evaluate, and find out the cause of this undiagnosed bleeding, vaginal bleeding. And once you make the diagnosis, give her the treatment. Like say if it is endometrial hyperplasia, treat her first and then you go in for HRT. Next is active liver disease, because we know that these hormones are going to be metabolized in the liver. Never ever put the woman when she's got active liver disease. And always, whenever you're starting the woman, it's a multidisciplinary team. You need to sit and talk to the woman. You need to take in all the factors into consideration before starting on HRT. So because HRT is a key topic here, at least try to remember what are the indications of HRT, what are the key risk factors, and what are the various ways of giving the woman HRT. So let's look into the common questions that you can expect here. First thing is diagnosis of menopause. It's 12 months of amenorrhea. Average age is 51. FSH level more than 30 is your diagnostic marker for menopause. Now, what is the key pathological features you see here? Estrogen is less, inhibin is less, FSH is more. Why is FSH more? Because of the loss of negative feedback of estrogen. Menopause. What is premature menopause? Whenever the woman is less than 40 years and she has got menopause, then it is called as premature menopause. Coming to the use of hormone replacement therapy, women has no uterus, give her only estrogen. Women has uterus, give her estrogen and progesterone, because the progesterone is the one that is going to protect the endometrium of the uterus. If the endometrium is not protected, she can land up in endometrial hyperplasia and endometrial cancer. That is the reason you use progesterone here. Coming to the risks of hormone replacement therapy, the transdermal route you can use to lower your risk of VTE. Venous thromboembolism is one of the deadly things that we see with HRT use. So be very careful. How can you avoid it? You can avoid it by avoiding oral hormone replacement therapy, and you can go in for transdermal route of hormone replacement therapy. Another thing is breast cancer risk. There's a slight increased risk of breast cancer when you use combined HRT. And why is the woman going in for osteoporosis or cardiovascular effects? It is because of loss of the protective effect of estrogen. So the key hormone that is lost is estrogen, and all the side effects are because of this hypoestrogenic state in menopause. So Finally, we're going into the last topic of discussion, which is on androgens. So let us look into androgens and the disorders in androgen, that is hirsutism and virilization. Now, androgen in women. What are the sources in a woman with which she's going to make the androgens? One is your ovarian theca cells. Next is your adrenal, the zona reticularis, estrogen to androgen. So what are the key androgens that we are talking about here? We look into testosterone. We look into the active form of testosterone, which is the androstenedione. We look into DHEA and we look into DHEAS. These are the key androgens that we deal with when we talk about androgens in women. Now, what happens is the sex hormone binding globulin. The sex hormone binding globulin is the one that binds to testosterone. When this binding takes place, your free testosterone is the only one that is active. So less amount of free testosterone is not going to cause any effect on the woman. But whenever the sex hormone binding globulin level goes down, your free testosterone level is going to increase. The binding factor reduces. So, what are the conditions that can cause reduction in the sex hormone binding globulin? It is most commonly seen in women with polycystic ovarian syndrome. It is seen in women who has got obesity. It is seen in women who has got insulin resistance. So, all these conditions, you have to remember testosterone rises. Why? Because the sex hormone binding globulin reduces in them. Now let's look into two different terminologies. One is called as hirsutism, other one is called as virilization. Now what is hirsutism? Hirsutism is nothing but excess terminal hair that is present in male pattern. So when you have this excess hair that is seen in face, chest, back of a woman, then you call the woman as got hirsutism. And how do you diagnose, or how do you classify this hirsutism? You have the scoring system which is called as Ferriman-Galway scoring. For puberty, we saw a scoring system which is called as Tanner staging. For hirsutism, it is called. What is the most common cause of a woman with hirsute features? Again, remember it is PCOS, because PCOS is the most common endocrine pathology that is seen in the reproductive age group. So, hirsutism, again, it is seen in PCOS women. We have another important terminology to remember here, which is called as virilization. Now, what is virilization? Virilization again is seen because of excessive androgen effect. So what happens in these women? There's a deepening of voice. This deepening of voice is going to change from a female voice to a male voice. Second thing, that can be clitoromegaly. And next, there'll be male pattern balding will be seen in these women. So they can have loss of hair and male pattern balding. The muscle mass might increase. And whenever a woman is presenting with virilization, you think about some tumors. Why? Because virilization is generally seen when the woman has very excessive amount of androgens. Hirsutism can be seen even with minimal elevation of testosterone, whereas virilization means there is severe androgen excess. So this woman needs to be evaluated for. Next, we have to look into the causes of this increased androgen levels. The most common cause is going to be polycystic ovarian syndrome. That has to be ruled out. Second can be some adrenal tumors or adrenal hyperplasia like congenital adrenal hyperplasia. Now, when we discussed on congenital adrenal hyperplasia, we were talking about the classical and the non-classical. It is presenting to you at a very, very acute stage. Okay, that is your salt wasting type, where the baby needs to be treated immediately. However, sometimes this congenital adrenal hyperplasia can present in a non-classical way. Okay, they can just have these features of hyperandrogenism later in their life. Okay, in early childhood or in early adulthood, they can just have this hyperandrogenic features. How are you going to diagnose it? Again, the test of choice is going to be 17-hydroxyprogesterone. So increase in 17-hydroxyprogesterone with androgenic features, think of congenital adrenal hyperplasia. Apart from that, there can be other disorders also like Cushing syndrome or androgen secreting tumors. So whenever you have a tumor that secretes androgen, say an ovarian theca tumor or a tumor in the adrenal gland, this is going to have a rapid onset and virilization is going to be very, very commonly seen here. Next will be the use of drugs. The use of anabolic steroids, the use of danazol again causes androgens. So how can this be presented in your exam? In your exam, they will say that this particular patient or this particular woman has been on steroids for some factor. So whenever you have such clues given in your clinical scenario, remember that these drugs are associated with hyper. Once we look into the causes, we look into the possible investigations that we have to do for these women. So first thing is you have to look at the testosterone levels. Whenever the testosterone levels is massively elevated, think of tumors. Whenever the level of DHEAS is elevated, you think of adrenal causes of hyperandrogenism. Whenever you have 17-hydroxyprogesterone level elevated, then you think of congenital adrenal hyperplasia. So this is how, based on the level of these hormones, you're going to diagnose the most possible cause. Next will be the rapid onset. So whenever you have a rapid onset along with virilization, then you think of, and when we look at the temperature going more than 5 nanomole per liter, then you have to do a rapid tumor workup, because rapid onset of virilization can be seen in tumors. So that is one thing you have to keep in mind. So what is the treatment of choice for them? The most common thing is the cosmetic effect this can have. So they can go in for cosmetic procedures like vaccine. They can use anti-androgenic drugs, your combined oral contraceptive, which has anti-androgenic effect, or they can go for other drugs like spironolactone, cyproterone acetate, and all that. However, the most key important thing is you have to look at what is the primary underlying cause and treat the underlying cause so that the woman is getting rid of this hyperandrogenic effect. So what did we see? We saw the various androgens in a woman. We saw the difference between hirsutism, virilization. We looked into the causes. We saw how these investigations are going to help, and finally the treatment. Let's look into a recall of what we just saw so far. First one is the androgens. The androgens in the woman can either come from the ovaries, or they can come from the adrenal, or they can come from the peripheral conversion of estrogen to testosterone. Second thing, only the free testosterone is active, and testosterone is free because of the sex hormone binding globulin. Sex hormone binding globulin is the one that is going to combine with testosterone, and your total testosterone will be high and your minimal amount of free testosterone will be present. And free testosterone is generally elevated in conditions like obesity and PCOS. Most common cause of hirsutism, PCOS. Hirsutism is nothing but excessive hair growth, especially in the male pattern. Virilization, whenever a woman comes across, remember there's a massive elevation of these hormones there. So think about tumors. Which is the marker for adrenal androgens? It is your DHEAS. Which is the marker for congenital adrenal hyperplasia? It is 17-hydroxyprogesterone. When, or what is the cutoff of testosterone for which you require a workup for tumor? Whenever it goes more than 5 nanomole per liter, you have to do a tumor work. With virilization, high testosterone, very, very urgently, you will have to do the workup for these women, because you are thinking in lines of tumor. What are the drugs that are called as, or which has anti-androgenic effect? Most common ones are your spironolactone and your cyproterone acetate. Cyproterone acetate can be given because it is a part of your combined oral contraceptive also. So these are the key factors that you have to remember with this. So we saw the basics of reproductive endocrinology also. Now let's look into some questions and let's try to answer them now. Okay. So the first question here is the first sign of puberty in girls. So we have menarche, we have pubarche, we have thelarche, we have growth spot, and we have axillary hair. Now, if you see, all these changes are seen in puberty. Which is the first one to come? First one is always the breast budding. Next one is your pubic hair. Pubic hair is because of androgenic effect. And then you have your growth spurt. Pubic hair and axillary hair come hand in hand because both are because of androgenic effect. And the last one to come is your menarche. So start with breast budding. 2.5 years later, the woman is going to get, or the girl is going to get menarche. That's how it is. Okay, so the first sign is always breast budding. And how are you going to, classify or, stage these people? It is based on Tanner staging of puberty. So second question here, Kalman syndrome is characteristically combines hypogonadism with what? Okay. Again, very commonly asked question because it has a very peculiar feature in Kalman syndrome. You have hypogonadism along with, is it deafness? Is it anosmia? Is it web neck? Is it cataract or polydactyly? Well, the answer for Kalman syndrome is anosmia. So coming to another key clinical scenarios. So PCOS is diagnosed by Rotterdam criteria. So what does the Rotterdam criteria require? Excuse me for one. So for PCOS, we know it is going to be the Rotterdam criteria. Now let's see what are the key factors or features of Rotterdam criteria. Is it like all the three features need to be present? Is it like two out of three features need to be present? Is it just the polycystic ovaries on ultrasound? Or is it just the raised LH-FSH ratio? Or is it a fasting insulin level? Well, for Rotterdam criteria, we require two of the three features. And what are the three features? Just for a quick recall, the first one is going to be oligo or anovulation. The second one is going to be clinical or biochemical feature of hyperandrogenism, and the last one is the presence of polycystic ovaries on ultrasound. So, I of the three features must be present to diagnose the Rotterdam criteria. Now, what are the other causes of other causes that has to be ruled out before you come to conclusion of PCOS? Other causes are congenital adrenal hyperplasia, Cushing syndrome, androgen tumors, thyroid disorders, hyperprolactinemia. All of them must be ruled out before you conclude with PCOS. So, going into the next question, which is the first line agent for ovulation induction in PCOS? Okay. Is it clomiphene citrate? Is it letrozole? Is it metformin? Is it gonadotropin or bromocriptine? Now, if you look into the question clearly asks about ovulation induction. So this is something I want you to keep in mind. All of these drugs can be used for a woman with PCOS. Metformin is for insulin resistance. Bromocriptine is for hyperprolactinemia. Gonadotropin, letrozole, clomiphene. All these three can be used for ovulation induction. However, the first line of drug is going to be letrozole. So remember, for your exams, if your question typically targets on ovulation induction, you need to go specifically. If they are going to ask you the first line of agent for treatment of insulin resistance, then you go with metformin. If they ask you the drug of choice for hyperprolactinemia, then you go with bromocriptine, you go with cabergoline. So this is how you choose your drugs. Why does PCOS increase the risk of endometrial cancer? Again, a very common pathophysiology of PCOS that is tested here. Is it because of excess progesterone? Is it because of unopposed estrogen from ovulation? Is it because of high FSH levels? It is because of raised prolactin, or is it because of low estrogen? So the risk of endometrial cancer increases always because of unopposed estrogen. There is anovulation, there is less progesterone, but it is not the cause. The main cause is your unopposed estrogenic effect that is seen in PCOS. So whenever the estrogen is there unopposed with progesterone, hyperplasia, this endometrial hyperplasia, it can turn into endometrial cancer risk. So what can you can do to protect these women? You have to give them withdrawal bleeds to protect the endometrium. So minimum once in 3 months, the woman has to have a bleed. Next, coming to the commonest cause of secondary amenorrhea. PCOS, pregnancy, prolactinomas, premature ovarian insufficiency, and Asherman syndrome. So whether it be primary amenorrhea, whether it be secondary amenorrhea, the commonest cause or the cause that has to be ruled out is always pregnancy. So in what are the other things you're going to think about? You think about PCOS, you think about hyperprolactinemia, everything can be thought about, but still the most common amenorrhea. If you have a clinical scenario in exam and they're dealing with primary amenorrhea and they are telling me, they're asking you what are the things you have to rule out. Again, remember, you have to rule out pregnancy even in cases of primary amenorrhea. Never miss on that. So next question, hypothyroidism can cause amenorrhea and galactorrhea because, okay. So this is thyroid and they're asking you about galactorrhea and amenorrhea. Let's look into the options. Low TSH suppresses prolactin. So whenever there's suppression of prolactin, you don't expect galactorrhea. So that itself rules out. High TRH stimulates prolactin. Yes, it can be a possibility. Let's just look into the other options. It rises FSH directly. It lowers estrogen synthesis. It can cause ovarian failure. Well, when you look at all the options, the most common one that can be associated with your raised TRH levels, which stimulates prolactin. Okay. Now, whenever the woman has got a primary hypothyroidism, what happens? The TRH level is high. This TRH level will lead to stimulation of your prolactin. So this prolactin causes hyperprolactinemia. Hyperprolactinemia causes amenorrhea by suppressing your GnRH, and also hyperprolactinemia causes galactorrhea. So whenever you're thinking in terms of prolactinoma, you should always rule out hypothyroidism also. These hormones are structurally similar and hence this cross action of these hormones are same. Next question is, in a woman with amenorrhea, high FSH indicates the problem is at the level of what? Okay, so we saw how do you differentiate the levels of amenorrhea depending on FSH levels. Okay, so hypothalamus and pituitary, what is happening? At the level of ovary, what is happening? At the level of uterus and vagina, which is your end organ, what is happening? So whenever your hypothalamus and your pituitary is affected, your FSH level is going to drop down. So you have hypogonadic states. Nothing to do with the hormonal levels. They are just your end organs. So just anatomical variations you expect. You do not expect a change in the hormone levels. So which is the one that is going to have a high FSH whenever there's an end organ failure? The end organ for your FSH is your ovaries. So whenever there's an ovarian failure or a problem with your ovaries, you can have high FSH levels. So what are the causes that can be in your ovaries? Can be because of premature ovarian insufficiency. It can be because of Turner's. Multiple causes are there. So hypothalamus and pituitary, if they are at fault, FSH is low. Ovary is at fault, FSH is high. End organ, that is your uterus and vagina, it is going to be normal. So, a woman without a uterus needs which form of hormone replacement therapy? Hormone replacement therapy, you have two drugs, estrogen and progesterone. So, if the woman is not got a uterus, there is no endometrium, so you don't worry about endometrial cancer. You give her only estrogen. If the woman has got a uterus, there is an endometrium which needs to be protected. So, you give her estrogen and progesterone. Both has to be given together. Okay, so this is the idea or the basis behind when will you choose estrogen, when do you choose both estrogen and progesterone. Moving on to the last question. Rapid onset hirsutism with deepening voice and a testosterone more than 5 nanomole per liter. So there are three important things that's given here. One, it is rapid onset. So something that's coming in very quickly needs a very fast investigation. Deepening of voice. Deepening of voice is nothing but virilization and very high testosterone level. All these three are present. You always think in terms of tumor. PCOS, idiopathism, constitutional delay, well, there will not be any of these changes there. So you think in terms of an androgen secreting tumor. Hence, you will have to do a fast workup and evaluate these women. So these are all the high yield recall maps. So we started with some main hormones right from the hypothalamus. Then we looked into the pituitary hormones. We gave a lot of importance to prolactin, hyperprolactinemia and the treatment of prolactin. And then we came into thyroid disorders. We looked at the changes in thyroid disorders, hypothyroidism and hyperthyroidism. And then we looked at the drugs that we use for thyroid. First trimester is propylthiouracil, and after first trimester, you're going to use carbimazole. Why you don't use carbimazole initially? Because it causes aplasia cutis. Then we came into adrenal disorders. We saw GFR, what releases what in adrenal. Then we looked into some adrenal disorders. Then we had a look into the calcium homeostasis. We looked into what parathormone can do, what calcitonin do, and what vitamin D will do. So this deals with your calcium homeostasis. Then comes the important clinical scenario of gestational diabetes mellitus. How do you diagnose? How do you treat these women? And finally, for reproductive endocrinology, we saw puberty, then we dealt with pubertal disorder. Importance was given to precocious puberty, delayed puberty, amenorrheas, and hyperprolactinomas. Apart from that, PCOS, how do you diagnose PCOS? How do you manage PCOS? These were the key areas we tested. Last, we saw menopause. Menopause, how do you diagnose menopause and how are you going to deal with hormone replacement therapy? These are some core areas we saw today, and this is some high topics of endocrinology which you can have a look. And with this, we conclude today's session. Just in case there is anything more that you would like to know or read in endocrinology, drop a message in WhatsApp and we'll be more than happy to help you guys. Thank you once again for joining in, everybody, and wishing you all the very best for your exams. Thank you so much.